two major minerals in the bone, the calcium and phosphorus, and they get deposited here. We also discussed in the last time that why doesn't the calcium and phosphorus get deposited in the blood, because it is circulating, is because of this substance which is pyrophosphate, which is inhibitor of mineralization. So these poly and pyrophosphate basically inhibit it. Now, what does osteoblast do? Osteoblast produces alkaline phosphatase, which destroys this pyrophosphate and allows the deposition of calcium hydroxyapatite, which has got 10 moles of calcium and 6 of phosphorus, which gets deposited in that regards. So calcium and phosphorus we need to understand to get the right idea about the bone physiology. 99% of our entire calcium is in the bone. We have around 1.2 kgs of calcium in the body. So it's one of the biggest amount of minerals that we have from that perspective. And we know only 1% is actually able to communicate with the plasma. Within the plasma, 40% is bound to albumin, 10% to phosphorus, and 50% is the ionic one, which is the one which we are concerned about. So calcium homeostasis, we all know that there are three major organs: the intestine, the bone, and the kidneys, and three major hormones: the parathyroid hormone, calcitriol, and calcitonin. So which ones are more important for acute and for chronic?
Parathyroid hormone.
Okay, and which system, which tissue out of these three? So acute is bone, chronic is intestine, because kidney is just you're losing how much calcium? Every day you're losing around
less than what?
So 4 is a peak. 4 is a definition of hypercalciuria. So you're losing a very little amount. So how much you take in is important, and acute will be your basically your immediate one. So you can say that maybe intestine is more like your salary, which is coming continuously in between, while this is basically as like a ATM card. You wanted to take it out immediately, while this is more like ensuring that you're not leaking out a lot of money. So this is how you can think of in terms of calcium. Now, in hormone perspective, of course, there is no doubt. PTH is number one, because PTH is not only controlling the bone resorption, the renal absorption, it is also working via the calcitriol pathway. The second one is calcitriol, and the least important is calcitonin. It all is sensed via the calcium sensing receptor, which basically is a G protein coupled receptor, and we discussed about that in detail. It is made in the endoplasmic reticulum, is glycosylated and pushed out of the cell membrane. It is going to sense calcium acting via the phospholipase C pathway and the GNA-AL1 pathway to really regulate the calcium levels. What all should a calcium sensing receptor activation do?
Activation will inhibits the PTH secretion from the parathyroid. It increases the calcium excretion via kidney. It increases the calcitonin production from the.
So its major role is chief cell of parathyroid to inhibit the PTH effect. Then thick ascending limb of Henle, it's going to cause calcium loss. With calcium loss, when you talk about Het and cyclic AMP, you will also have the electrochemical gradient going off, and you will have polyuria, which is going to happen. And of course, parafollicular cell, it is going to increase the calcitonin level. What will it do to magnesium?
It senses the magnesium as well due to the structural similarity. And if it senses, it can, if it is an activating mutation, then the magnesium, there will be absorption of the magnesium possible.
So if it's an activating mutation, it is going to cause hypocalcemia and hypomagnesemia. If it is inactivating mutation,
it will cause magnesium loss, because it sense like the magnesium is high in the body, so it will cause.
And if it is inactivating, then you will have hypermagnesemia, and that's where we talk about if it is a primary hyperparathyroidism, magnesium is low. If it is calcium sensing receptor related hyperparathyroidism, magnesium is high. So magnesium is a very good clue to differentiate the two conditions. Yeah, and bone, of course, it does a regulation. So calcium sensing, we said it goes to the parathyroid. It is going to say, okay, we have enough amount of calcium, shut down the PTH. It's going to say the kidney, okay, now remove the calcium. From that perspective, go to the parafollicular area and say, okay, my calcium is more. Now calcitonin, you come into the picture, prevent the hypercalcemia, which is happening. And based on that, you will easily understand what will happen if you have too much calcium sensing receptor. You will have hypocalcemia with hypercalciuria. If you have too little effect, you will have hypercalcemia with hypocalciuria. So these are the major effects. Now, as I said, the long-term salary of your body is how much you're getting it out from the intestine. And intestinal absorption, therefore, is a major regulator of your calcium levels. Now, we know that calcium will come largely from dairy products, a bit also from green vegetables. And this calcium can be absorbed through the transcellular pathway or the intercellular pathway, in between the cells and through the cells. Through the cells has to be an active process. So this has to be regulated more. Transcellular is regulated less. Phosphorus and things which are associated with calcium binders will decrease the calcium absorption. So if you take a lot of colas, if you take a lot of green leafy vegetables, they can also sometimes clog. They will phytates are there which can also block the calcium absorption. Now this calcium which goes through the intercellular region, this is not regulated. So this is going to continuously increase. So there is no limits to how much your calcium can be. So if you take a lot of calcium, your calcium levels may go up. The one which is regulated is largely which is going through the cells or the transcellular pathway. Now, unregulated, as I said, if you have you can have hypercalcemia if you drink a lot of milk from that regards. Now, this calcium which goes through the cells is largely driven through the TRPV pathway, the TRPV6 and the calcium one. So there are different ones in duodenum and in the jejunum. So major absorption happens at the level of duodenum. From there, the calcium goes inside. There are calcium binding proteins which basically take it down. Something like what we discussed about the chylomicron and the lipid. They had a similar mechanism, packaging protein, bringing it down. And from there, it is pushed out via the calcium ATPase process. So there is an active process through which the calcium is being absorbed. And one of the most important regulator of this process is calcitriol. So the only hormone which affects calcium absorption is calcitriol. There is no effect of PTH, minimal effect of calcitonin. So calcitriol actually acts on the vitamin D receptor at the level of TRPV6 to increase the calcium absorption from that perspective, and therefore your calcium absorption increases from 25% to 40%. So only 1.5 times more calcium you are going to absorb. So for vitamin D to act, vitamin D to increase your calcium, what is essential? You need to have calcium. For aldosterone to act, you need to be taking sodium. If you're not taking sodium, aldosterone is not going to do anything. So similarly, if somebody is not taking calcium, vitamin D alone is not going to work. What it also means is that this intercellular pathway, even without vitamin D, it will absorb calcium. So in newborns, the major regulation of calcium absorption is not through vitamin D. So in the first 15 days, 2 weeks, 3 weeks, you will not have any problem if the vitamin D levels are low. That is why the onset of hypocalcemia in the neonatal period is typically beyond 3 weeks of life, and most commonly we see around 6 to 8 weeks. That is the infantile hypocalcemia. The other message is that if you start vitamin D at the right time in a newborn, even if there is zero vitamin D to begin with, you may be able to take care of and prevent at least the hypocalcemia part. From that regard, that becomes important to understand. So vitamin D status, basically, as I discussed, without vitamin D, you will have 25% absorption, and with vitamin D, you will have 40% absorption, which is important. You, of course, need more during adolescence and pregnancy and lactation. So, which means the hormones which are more in adolescence, like estrogen, in pregnancy, lactation, like prolactin, they are going to increase your calcium absorption, as does growth hormone. We already discussed about that in that regard. So growth hormone, estrogen and prolactin increase the calcium absorption. So if you understand what is required at different stages, which hormone work, you can automatically derive, and then you can get this hypothesis right from that perspective. While glucocorticoid and thyroid, they are going to decrease one, as we discussed earlier, also from that regards. Now, kidneys do not play a very, very important role in the actual calcium levels. As I said, hypercalciuria is 200 milligrams per day, but that is not going to make a big difference. But they play a very important role in the development of renal calcification, and they are also important when you want to assess the cause of hypocalcemia. So, most of the calcium that you have is reabsorbed at the level of the PCT, around 70%. But if you know, think about sodium, how much is reabsorbed there? 99, 98%. So it's much lower, but 70%, most of it is going here. And this is mediated by the calcium sensing receptor. So this is where the calcium sensing receptor comes into the picture. Out of the remaining calcium, some of this is getting reabsorbed via the Claudine pathway. And where have you heard about the Claudine pathway? In which pathophysiology? So hypomagnesemia is one of these conditions where Claudine problem can be there, and they are associated with nephrocalcinosis because they are going to lose a lot of calcium in the kidneys. So beyond that, there is a distal tubular absorption by around 5%, and this is that 5% which is the TRPV5 mediated, which the PTH controls. So we all know that PTH conserves serum calcium, but it is only 5% of the total filtered one. So if you are filtering 200 milligrams, it is going to control around 10 milligrams. But that may be good enough to prevent your nephrocalcinosis. It's not good enough. So when somebody says, okay, PTH acts on the bone, it acts on the gut via the calcitriol, and also acts on the TRPV5, are they equally important? No. This is a very, very minor effect. But what it does is that it prevents nephrocalcinosis. So which brings to the question, if you have a same level of calcium in somebody with hypoparathyroidism, pseudohypoparathyroidism, or hyperparathyroidism, who will have the maximum amount of renal loss of calcium or urinary calcium? Suppose you were able to make their calcium as 10. Yes? Yeah, and hyper will have the lowest chance because that conserving effect of PTH will be there. So it is paradoxical. Hyperparathyroidism should cause hypocalciuria, but it causes hypercalciuria because their calcium is high. I would say we can use the term of relative hypocalciuria. For that level of calcium is 16, you are anyway going to lose. Similarly, hypoparathyroidism should cause hypercalciuria, but because your calcium is so low, you're not filtering. That is why you have hypocalciuria. And calcitriol also plays a role here. Thiazide diuretics also play an important role, and we know that thiazides are used for treatment of idiopathic hypercalciuria, while furosemide are going to increase the calcium loss. And long-term furosemide use, particularly in preterm neonates, is associated with nephrocalcinosis. That is because of the loss here. There's also absorption at the renal tubular level, which happens via Claudine 16, and this calcium also similar the TRPV cal binding protein. A similar mechanism is there, and PTH plays an important role, which we have discussed. If you have more sodium load, your calcium becomes more. So what do you suggest somebody with distal RTI about the sodium load? Should they have more sodium, less sodium?
Regarding the nephrocalcinosis part, they should have lesser sodium.
So less sodium. Salt restriction is important because otherwise if you give too much salt, when you have too much salt, what will happen? What else will happen?
Acid will leak out again.
So potassium, all the positive ions will leak out. Acid will leak out. So your proton is going to leak out. Acid is not going to leak out because there is a problem in distal artery. So your potassium is going to leak out, your calcium, your magnesium, everything is going to leak out. So that you don't want. So decreased sodium intake becomes important. And why do you give sodium to these people? Do you give sodium to them? The treatment is soda bicarb. So some people say if you give sodium potassium, it may be a better agent. But whatever it is, do not overtreat. That is the main message which is coming from that perspective. In activating calcium sensing receptor demutation, the parathyroid is thinking you have got a lot of calcium. It is not giving anymore. And the kidneys are thinking they are too much calcium, but is losing a lot. So that is a problem which happens from that regards. And acidosis we discussed is a clear-cut reason for hypercalciuria. So do proximal RTA individuals have hypercalciuria? And if yes, why don't they develop nephrocalcinosis? They have acidosis, they have hypercalciuria. I have given the clue. But why don't they develop nephrocalcinosis?
Because of citrate.
Yes, citraturia is there and that can prevent that. So that understanding becomes important. So people say, okay, hypercalciuria is there. This is distal RTA. That's not true. It can still be proximal RTA where you have hypercalciuria. So skeletal metabolism, if we discuss that 99% of the calcium is here, 1% is in the circulation, and we have got PTH, which is going to bring out the calcium from there, and this calcitone is going to push it back. So this is an exchange mechanism. So this is a rapid regulation as we discussed from that regards. Very importantly, people talk about what is the normal PTH level. There is no normal PTH level. It has to be interpreted in the light of your serum calcium level. So as your calcium is low, your level should be high till a particular level, and then it is going to be static. And then as the calcium level increases, it falls down till it becomes zero at a particular time. So this is the sort of a graph that you look at, a sigmoidal sort of a graph which is there. Now, calcium sensing disorders will cause different problems. If your calcium sensing is less, what will happen to this graph?
It's right.
It is going to be shifted towards the right side. So what it means is that for every level of calcium, you will have a higher level of PTH. So you will have a hypercalcemia. While if it's an activating disorder, it's going to be shifted towards the left side, which basically means is that for every level of calcium, your PTH level will be low. So you will have hypocalcemia with hypercalciuria. So if you understand the physiology, it becomes much easier to overall guess from that perspective. Now, PTH, as I discussed, is a major factor which is regulating that. We also need to understand how PTH works. So PTH is produced by a pre-pro PTH, like pre-pro GnRH, like pro-opiomelanocortin, like pre-pro insulin, and it is processed. It cannot be there for a long time. It's degraded. So its half-life is very less. So either it is secreted or degraded from that regards. The major regulator here is calcium sensing receptor. More calcium sensing receptor, less amount of PTH, which is there. And this is going to have a multitude effect. Long-standing hypercalcemia is going to shrink your parathyroid as well. So that can cause parathyroid atrophy. On the other hand, long-standing hypocalcemia is going to increase the parathyroid size, and this may lead to development of parathyroid adenomas. We talk it about as tertiary hyperparathyroidism. Now, immediate effect is, of course, on release. Intermediate effect is on synthesis, and long-term effect is about on the hyperplasia, which may happen with calcium deficiency. What does phosphorus do to PTH? What should it do? So more phosphorus inhibit PTH. More phosphorus.
More phosphorus will stimulate PTH.
So high phosphorus is a trigger of PTH secretion. Why is it relevant in hypophosphatemic rickets? If you give too much phosphate, your phosphorus goes up, PTH gets stimulated, it's lost. So better to give fractionated multiple times a day. Don't want to raise it too much. You don't want to make it angry to take it out from that perspective. So this is important. Phosphorus is going to inhibit PTH. Magnesium has a very clear relationship, and we talked about that magnesium, if it is too much, is also going to inhibit. If magnesium is too little, it is going to decrease the sensitivity to PTH and the release of PTH both. So hypo as well as hypermagnesemia both are going to impact the PTH. So PTA phosphorus is going to increase, magnesium is going to decrease. What about FGF23? Increase, decrease?
Decrease.
Decrease. Why?
Because if GF23 is secreted when we want to secrete the phosphate out of the body. So if GF23 is high, the PTH must be low, so that the bone doesn't get dissolved and phosphate doesn't get converted.
So don't produce too much phosphorus loss. You want this like a safety mechanism. The other way to look at it, what does PTH do to FGF23?
It stimulates it.
So there has to be. In endocrinology, you will never have negative or positive feedback except for the rare situation of LH surge. So if something is stimulating B has to suppress that. So FGF23 is basically going to decrease the amount of PTH, and calcitriol, of course, is going to decrease PTH, because if you have more calcitriol, calcium is getting more. You don't want your PTH to be more. And PTH is increasing calcitriol. So, of course, that cycle otherwise will become very vicious from that perspective. So, that becomes important. PTH action again acts via the type 1 PTH receptor, which is common for both parathyroid as well as parathyroid related protein. And it acts via the G protein receptor, cyclic AMP pathway, as well as the effect on other parts like phospholipase, IP3 DAG, and beta arrestin. Now, based on this, what we are seeing is that PTH is acting not only through this GNAS pathway, it is also acting via the GQ pathway and the beta arrestin pathway. So, which one is going to be more severe, hypo or pseudo-hypo parathyroidism? Yes, because 3 pathways are affected, while in pseudo-hypo only 1 is affected. So that is why pseudo-hypoparathyroidism typically presents around 1 year, 2 years, that sort of a life. Hypocalcemia is rare in infancy in pseudo-hypoparathyroidism in that regards. And if you have too long effect, the overall process becomes desensitized and the receptor goes down, which causes, if you have too much PTH stimulation, there will be desensitization which happens. And in individuals who have severe vitamin D deficiency, typically in infants, you have secondary PTH resistance which may happen. Now, PTH 1 to 34 is also good enough from that regards, and this is known as, this is the active form of parathyroid, which is the teriparatide, and 1 to 31 also has a significant role from that regards. So vitamin D deficiency, as we discussed, in the long run will have a secondary PTH resistance, producing a quote-unquote pseudo-hypoparathyroidism like picture from that regards. Finally, the effect of PTH on the bone we already discussed. It has an effect on osteoblast, and through osteoblast on osteoclast, causing calcium resorption from the body. It increases FGF23, and it also has an effect on kidney, which we discussed, mainly at 1-alpha hydroxylase, as well as a TRPV5 to cause calcium absorption.